Welcome everyone to the Antimicrobial Stewardship Project webinar series created by the Center for Infectious Disease Research and Policy at the University of Minnesota. I'm Dr. Marnie Peterson, your moderator today, and also your host. I'm the outreach coordinator for the Antimicrobial Stewardship Project. Today, we are pleased to have Professor David Lai from Singapore as one of our speakers, and also Professor Deborah Williamson from Australia. They will be giving their presentation titled The Value of Diagnostics in Antimicrobial Stewardship, an Asia-Pacific Outlook. I have a few slides before they begin their presentations to give our listeners some instructions. We really want this to be an engaging webinar, and we will have a Q&A session, question and answer session where you can engage with our speakers at the end of our webinar. You can submit questions, as you will see, either from your laptop devices or your mobile devices, a box where you enter your name, email, and ask your question, and then don't forget to hit submit. We look forward to receiving your questions that you can submit throughout the entire webinar. Also, at the end of the webinar, we would love to have your feedback. There will be a feedback submission page. If you've logged in as an individual viewer, you'll be immediately prompted to go to the submission page, feedback submission page, so you can provide us information about the webinar and the quality of the webinar and how it will impact you in your field and your practice. Also, an attendance certificate will be available after the feedback submission. If you're a viewer in a group, we will also be sending you an email for where you will be directed individually in a few hours, where you can then have the link for feedback submission and a PDF certificate that you can download. Importantly, this webinar is providing continuing education, both continuing education for pharmacists as well as for physicians. ACCME is our continuing education for physicians, both by listening to this webinar, and then you have to complete a post-test question and evaluation at the end. We will give you the information of how to complete that evaluation, and following that, you'll receive 1 contact hour for this webinar. Our target audience for the webinar is to meet the educational needs of clinicians, including physicians, pharmacists, physician's assistants, other healthcare professionals such as nurses and laboratory scientists. And importantly, we'd like to thank our sponsor of this webinar, bioMaru, as they have supported this activity by an educational grant. For disclosures, the names listed in the upper left-hand side are all of those either speaking today or have been part of the faculty for the development of the webinar, and they have nothing to disclose, nor do our planners. Finally, the online evaluation and self-assessment will occur at the end, and we will give you the information again at the end of this webinar. Importantly, you need to go to a website link, which we will be also emailing all of you the details for this evaluation, where you can then complete the post-test and print your CE statement of completion. You will also be provided an attendance code, which you will need when you log into this website. That will be on the last slide of the webinar. And the deadline for submitting to this website with this attendance code today is December 6th, 2019. We have learning objectives, and we have 2 speakers, and these learning objectives, basically there are 2 for Professor Lai's presentation and 2 for Professor Williamson's. First, Professor Lai will describe evidence-based clinical and laboratory considerations for selecting appropriate antibiotics. He will then explain the benefits of antimicrobial de-escalation, including the route and duration. Professor Williamson will define diagnostic stewardship, how it's linked to antimicrobial stewardship, and leads to improved patients' outcomes. Finally, she will describe the selection and interpretation of diagnostic tests, including traditional and rapid diagnostic assays. There are many other components and contents to this webinar, but these are the objectives. So we will begin the first component of our webinar. The title of this is Webinar Learning by Case Vignette, Appropriate Antibiotic Use, given by Professor Lai. As you can see from his title slide, he's a senior consultant in the Department of Infectious Diseases at Tan Tock Seng Hospital, Director, Infectious Disease Research and Training Office, National Center of Infectious Diseases, and he's an associate professor at 2 universities, Li Kong Cheng School of Medicine at Nanyang Technological University and Yong Lu Lin School of Medicine, National University of Singapore. With that, I'd like to welcome Professor Lai to begin his component of our webinar today. Professor Lai, go ahead and unmute yourself when you're ready.
Okay, can you hear me now?
Yes, we can. Thank you. Welcome to the webinar.
Thanks for introduction. It's my pleasure to be presenting at this case to illustrate principles of antibiotic use. Let me begin. We have a 79-year-old man from a nursing home with moderate dementia needing assistance with activities of daily living and a walking frame. His medical history included hyperlipidemia, sick sinus syndrome with a pacemaker, pulmonary embolism, and deep venous thrombosis. He had no drug allergy. He did not smoke or consume alcohol. He presented to the hospital with 3 days of fever without chills and rigors, initially treated by a general practitioner with oral amoxicillin clavulanate, but he now had a full blood count performed, which revealed a leukocytosis of 41,000. On systematic review, he reported mild cough with white sputum. There was no runny nose, sore throat, chest pain or breathlessness, no vomiting, diarrhea or abdominal pain, no dysuria, no travel or sick contact. On examination, there was a low-grade temperature of 37.5, pulse was 76 beats per minute, blood pressure was 154/83, respiration was 18 per minute, and oxygen saturation 99% on room air. He was alert-oriented with no jaundice and no lymphadenopathy. He had double heart sounds with no murmur. Some left basal crackles with reduced breath sounds were detected. His abdomen was soft with mild tenderness on the right flank without rebound or guarding. Significantly, Murphy's size was negative. There was no loin tenderness. Digital rectal examination revealed brown stool. Calves were soft with no leg edema. This is his full blood count, confirming a white blood cell of 41.3 thousand, predominantly neutrophil, as well as a platelet count of 94,000. His renal function was normal. Importantly, he had a mixed picture of his liver function. ALT was 355, AST was 102, ALP was 353, and gamma GT was 357. C-reactive protein was 221, and amylase was 219. At this point, a question can be posed. Would you order C-reactive protein or procalcitonin? Yes, C-reactive protein only. Yes, procalcitonin only. Yes to both or no. Now, this is not interactive, so I'll go through the rationale behind this question. When the white cell count is extremely elevated, in fact, it is extremely useful to differentiate bacterial from non-bacterial infection. These are 3 studies that illustrate this. The first one shows that white cell count of more than 15,000 differentiated between acute bacterial and viral meningitis. The second one showed that the same threshold differentiated between acute bacterial and tuberculosis meningitis. And the third one was looking at occult sepsis in adults, and it shows that 15,000 of white blood cells identify adults with acute occult bacterial sepsis. What about ProCE and CRP, two biomarkers of sepsis, which are quite commonly used? This is a meta-analysis many years ago now, and it looked at the differentiation between bacterial and no infection and bacterial and viral infection. You can see that for CRP, the sensitivity was around 75%, the specificity about 67%. ProCE sensitivity was a bit better at 88%, specificity at 81%. The important take-home message is, if these two markers are elevated, you should be looking for a source of sepsis, but the specificity is nowhere near 100%. So if you, after careful evaluation, not find a source of infection and the patient improves, then you need not be treating the number. I'll now move on. So this is a recent commentary in JAMA to highlight 4 moments of antibiotic decision making. The first moment is always to ask, does this patient have an infection that requires an antibiotic? So in this particular patient, the white cell count was exceedingly high. Potentially, there is a source of bacterial sepsis. Have I ordered appropriate cultures before starting antibiotics? And what empirical antibiotics should I initiate? This will be addressed by the next questions subsequently about what is a likely diagnosis, because each diagnosis is underpinned by likely microbiology and that will inform the empirical antibiotics. After a day or more and you have the results back, can you narrow the antibiotic? Can you change from IV to oral? This is very important to remind us not to continue IV antibiotics indefinitely. And the fourth moment is what's the duration that's needed for the pre-diagnosis supported by randomized controlled trial. We'll now move on. So what was the likely diagnosis? Is it healthcare pneumonia because the patient came from a nursing home? Is it community-acquired pneumonia? The patient did have abnormal liver function tests. Could it be cholecystitis? How about cholangitis? And the patient did have some suprapubic right flank discomfort. Could it be pyelonephritis? We will now go through the thinking behind this. White cell count was 41,000. So if this is a pneumonia, it is a severe pneumonia. But this patient did not have prominent respiratory symptoms, only a mild cough with no chest pain, no breathlessness, tachypnea, hypoxemia, despite lung crackles and deep breath sounds. A chest X-ray will be needed to confirm or exclude pneumonia, but at this point, based on history and examination, it is not highly likely because severe pneumonia usually is associated with respiratory compromise. Now, even though there was a right flank pain may suggest pyelonephritis, there was no urinary symptoms. Noted that there was moderate dementia, but this patient was still able to give history. There was abnormal liver function test plus right flank pain. This may favor cholecystitis. Cholangitis was less likely without prominent jaundice and significant hyperbilirubinemia. So the next question, what was the most helpful next investigation? A chest X-ray, imaging of the abdomen, blood cultures, urine cultures, or no investigation, but start with empiric broad spectrum antibiotics. This could be because we are very certain of our diagnosis, or this could be because we want to save cost. Now, the pre-test probability for pneumonia here is relatively low, so chest X-ray is expected to show no consolidation. We'll review the results later. Ultrasound complete tomography of the abdomen may be indicated here because of right flank pain and abnormal liver function tests. A positive blood culture is certainly useful because it will localize the site of infection depending on what bacteria are isolated, and the antibiotic susceptibility can guide targeted antibiotic therapy. Urine culture is not very useful here because even if it's positive without urinary symptoms, it may be acinetobacteriuria, which is a common cause to lead doctors to overtreat positive urine cultures. Now, given the very high white cell count, severe bacterial sepsis is likely, and blood cultures are certainly indicated before starting intravenous antibiotics. So this is the chest X-ray. Essentially, although it is under-inspired, slightly rotated, it shows that both lung fields can be seen, heart borders are well seen. You can see the hemidiaphragms and the costophoric angles. Pneumonia is fairly unlikely, which is supported by the clinical syndrome. So this is a very old systematic review in JAMA. These are the summary from the review. No particular symptom can exclude or confirm presence of pneumonia on chest X-ray. However, if there's no tachypnea, no tachycardia, and no high-grade temperature, the probability of pneumonia will be very, very low. The specific signs for pneumonia are asymmetric respiration, vocal resonance, and percussion dullness. However, they're not very common. The prevalence is about 5%. The absence or presence of crackles is unable to actually confirm pneumonia. It is very common, but specificity for pneumonia is about 5%. So chest X-ray is usually needed to confirm pneumonia, especially in the hospital setting. In terms of blood culture, this study illustrates the importance of collecting adequate blood culture. You can see from table 1 that 5 ml of blood culture bottle versus 10 ml will have a lower yield, and 2 bottles will be better than 1 bottle. And on the right, in the table on the right-hand side, table 2, you can see that both bottles are likely to detect earlier, and the 10 ml bottle will detect earlier than the 5 ml bottle. So it's very important to send enough blood cultures. Ideally, 2 sets of blood culture bottles. That's about four bottles. Now, traditionally, there's a lot of teaching about taking blood cultures with fever and so on. This study examined whether the yield of blood cultures is determined by the timing or the intervals. So you can see from the table that 10 minutes to 2 hours, 2 to 24 hours, anytime in 24 hours, they don't really matter. And what is important in this study is that increasing cultured volume from 20 to 40 ml increased the yield by 20%, and increasing it for 40 to 60 ml increased the yield by additional 10%. So it's the volume of the blood culture that's the most important. Do not send blood culture bottles with a few drops of blood. Now, this is about urinary culture without symptoms. This is a syndrome that's extremely common. So you can see that in young women can be up to 5%, in diabetic patients range from 10 to 30%, in elderly persons, regardless of gender, about 20%, and in the elderly patients in nursing homes, it can be 40 to 50%. Is there any evidence that we need to treat colonization to prevent infection? In fact, there are 5 randomized controlled trials examining a range of settings: ambulatory women, institutionalized women, institutional veterans, mainly men, and so on. You can see that the conclusion out of all this is that there's no clinical impact in terms of recurrent UTI, in terms of mortality, but what you will find in the fine print of these outcomes is that if you do treat them, they're going to get infection with resistant bacteria or fungus later. So this is the result of the patient's blood culture. It revealed an E. coli with no ESBL detected. There was resistance to cefazolin and cefuroxime, but otherwise it's very sensitive. So even though the history and examination of patients may make it possible to be hepatobiliary or urinary, we now have an E. coli. What should we do with these results? What would be the best antibiotics? Should we use IV ampicillin, which is the most narrow spectrum? Should we keep it broad, like IV ceftriaxone? How about IV piperacillin tazobactam? How about IV meropenem? And how about oral ciprofloxacin? Can we use oral antibiotics? culture is important because if it is positive, it can be used to select the most adequate antibiotic. I will share some meta-analysis data to support this statement. In this case, it may be IV ampicillin. Now, increasingly, oral antibiotics with high oral bioavailability may avert the need for cannulation and complications related to IV therapy. So this is the meta-analysis of de-escalation of antibiotics in intensive care units. As you can see, the definition for de-escalation here in 14 out of 14 studies was a selection of narrow-spectrum antibiotics. In 13 out of 14, to reduce the number of antibiotics. In 5 out of 14, in culture-negative cases, and then in 4 out of 14, to shorten the duration or stop altogether. Now, when you narrow the spectrum of an antibiotic to treat a proven infection, you really don't, what you're concerned about is, are you going to increase the mortality? So in this meta-analysis, it actually shows that de-escalation was associated with low mortality. Now, this simply means that there is a selection bias. Doctors are more likely to de-escalate when patients are less sick. But importantly, what it shows is that it did not increase mortality. How would you administer the antibiotics? Complete the entire course with intravenous antibiotics for 1 week, complete the entire course intravenous antibiotic for 2 weeks, give intravenous antibiotics until no fever for 1 day, then oral antibiotics for 1 week, or give intravenous antibiotics until no fever for 1 day, then oral antibiotics for 2 weeks, or give oral antibiotic for 1 week. What could be the evidence underlying this question? It's common to start with intravenous antibiotics. For many common infections, such as pneumonia and pyonephritis, intravenous to oral antibiotic switch, once there's no fever, stable vital signs, and good oral intake, is now commonly practiced, supported by randomized controlled trials. There's now a randomized trial for 7 days of treatment for gram-negative bacteremia, just published last year. It has increasing retrospective observational data supporting oral antibiotics for treating gram-negative bacteremia. The only randomized trial is in pyonephritis with bacteremia. We'll now look at some of this. So this is a large cohort study in US, propensity matched with about 1,500 patients. The bacteremia came from a urinary source in 40%, gastrointestinal 20%. The 30-day mortality for oral step-down was 13%, and for containing intravenous antibiotic was 13%. There's no difference in recurrent bacteremia, and the hospitalization was 2 days shorter in the oral versus intravenous arms. There's a recent meta-analysis looking at which oral antibiotics can be used. In particular, looking at high bioavailable antibiotics such as fluoroquinolones and cotrimoxazole versus beta-lactams. You can see that looking at the forest plot for all-cause mortality, there was no difference. 8 studies, 2,000 patients. However, in terms of recurrence of infections, fluoroquinolones perform better than beta-lactam. In terms of recurrent bacteremia, although it crosses 1, there was also odds ratio in favor of fluoroquinolones. So if you're going to use IV to oral step down in serious gram-negative bacterial infections, it may be at this stage prudent to use a fluoroquinolone. This is a large cohort study from the same 3 hospitals in the US looking at the duration of treatment for gram-negative bacteremia. So you can see that there was imbalance in the baseline cohort, so they matched the cohort, and there were 385 patients treated for 6 to 10 days, and another 385 patients treated for 11 to 16 days. Not surprisingly, majority E. coli and Klebsiella accounting for about 80%. So in the lower table is the predictors of 30 days mortality. You can see that end-stage liver disease and pre-bacterial score, which is a measure of acute illness severity similar to a Petri II score, independent associated with 30 days mortality. And the unique source was associated with low mortality. Importantly, a short course of therapy was not associated with all-cause mortality. This is the one randomized control trial published last year, conducted in a few hospitals in Israel. They randomized patients to 7 days of antibiotics versus 14 days. Whether it's IV or oral is left up to the doctors. The primary outcome is a composite one: 90 days all-cause mortality, readmissions, extension of stay, distant complications, local suppuration, and relapse bacteremia. And you can see that there was absolutely no difference. They also examined a secondary outcome, 14 days and 28 days mortality, and once again, there was no difference between the two arms. Now, we do hope that treating for shorter will lead to less side effects and less resistance. Unfortunately, there's also no difference in diarrhea or Clostridium difficile infection. For this patient, as you can see, after admission, the fever settled promptly, and he seems to be improving clinically. Well, do you routinely order abdominal imaging for gram-negative bacteremia? Yes or no? Now, some doctors may not, in a very clear-cut case of bowel nephritis with rapid clinical improvement. In this patient, the diagnosis is more likely to be hepatobiliary, and there's very highly elevated white cell count. I decided to order a computed tomography. And in fact, what it reveals thickening of the gallbladder wall, suggestive cholecystitis. It also reveals dilated common bile duct with gallstones, suggestive of cholangitis. And importantly, there was opacified portal vein, suggestive of portal vein thrombosis. You can also see that the lower cuts of the CT scan shows the lungs, which did not reveal any consolidation, although there's a sliver of pleural effusion. So in fact, the abdominal imaging here is very important because with portal vein thrombosis, it is an endovascular infection. It will influence the decisions on the duration of antibiotics. So the patient underwent endoscopic retrograde cholangiopancreaticogram with symptotomy, successful extraction of multiple gallstones. Source control is extremely important in the treatment of bacterial sepsis. That's the end of my presentation. Thank you.
Thank you, Professor Lai, very much for your interesting and clinically driven presentation. We'll now advance the slide to begin Professor Williamson's presentation. And as we do that, I just want to remind our listeners today to go to your chat box that is located on your PC or laptop or on your mobile device, into that box and enter your questions for Professor Lai and Professor Williamson. Just a reminder, we'll have a question and answer session at the end of the presentation, and we really would like to engage with you. So to introduce the second part of our presentation, the title is The Value of Diagnostics in Antimicrobial Stewardship, the Role of the Laboratory. This will be presented by Professor Deborah Williamson. She's an associate professor at the University of Melbourne, Deputy Director, Microbiologic Diagnostic Unit, Public Health Laboratory, Director of Microbiology, Royal Melbourne Hospital. So she definitely has a laboratory perspective and will be giving us a very interesting presentation. Welcome, Professor Williamson. And once she comes, takes herself off mute, we'll be able to bring her on live. And
thank you, Marnie. Can you hear me?
Yep. Yes, I can. Welcome.
Thank you. Thank you. And as Marnie mentioned, my name is Deborah Williamson, a clinical microbiologist in Melbourne. And following on from Professor Lai's clinical vignette, I guess I want to take a more laboratory-focused view and talk about stewardship within the laboratory. And I guess, you know, when we hear the term stewardship, we often think first of the traditional antimicrobial stewardship model that really relies on infectious diseases physicians, pharmacists, or both, that is designed to implement measures that reduce inappropriate antibiotic use and prevent medication-related adverse effects and manage costs. But what I want to focus on, I guess, is what we mean by the term diagnostic stewardship. And you know, here I think it's important to note that the clinical microbiology laboratory is really in the midst of a diagnostic revolution with molecular diagnostic technologies, and these have the potential to transform the clinical microbiology laboratory and patient care by providing rapid microbiological diagnoses. But implementing these tests can come, I guess, with practical challenges for the laboratory and indeed for clinicians as well. I want to go through these three areas that I've highlighted here. But I think it's important to go back to first principles and really think about what the core function is of a clinical microbiology lab and what clinicians ultimately want to know from the lab. And that is, does the patient have an infection? If so, what is that infection? What pathogen or pathogens are causing it? And what can I use to treat that infection? And in the time frame between collecting the specimen, identifying the organism, and performing antimicrobial susceptibility, often broad empirical antibiotics are given to patients to, I guess, avoid the serious consequences of untreated infections in a few patients. So how can the laboratory provide a rapid and reliable result that can be used to provide answers to these questions faster and more accurately than ever before? And rapid diagnostics can really potentially reduce this time and provide earlier, effective, targeted antimicrobials and decrease the use of unnecessarily empirical antibiotics. And these technologies, in the context of diagnostic stewardship, will be the focus of this talk. So what actually is diagnostic stewardship? Well, there are several definitions mentioned in the literature, and I guess in the most narrow sense, diagnostic stewardship has previously been defined as the cost-effective use of laboratory tests. And although this is one component of diagnostic stewardship, it's not by any means the bigger picture. On the left of the slide are two recent definitions which really converge around common themes, and those are ensuring the appropriate use of tests to improve patient care and to reduce antimicrobial resistance. And these themes can converge even further around, I guess, an even simpler definition, which is basically making sure that the right test is performed on the right patient at the right time. And in the context of the rapid diagnostics that I've mentioned, diagnostic stewardship really requires a serious reconsideration of current practices as empiricism gives way to diagnostic guided therapy. So this table here from Messicard et al. And JCM a couple of years ago highlights even further the key considerations and strategies for the diagnostic stewardship process. And if we look at the top part of the table about selecting the right test, this really includes more than just the analytical performance of the test, i.e. just the sensitivity and specificity of the test. And in this instance, predictive values specific to the local population are often more helpful than just sensitivity and specificity. Other factors to consider around selecting the right test are obviously around cost and the implementation, so the feasibility of being able to implement that test in the laboratory versus, I guess, the clinical value of the test. So it's really important to liaise with clinical teams when you're introducing a new test. Next, we can think about directing testing towards the right patients. An overuse of these rapid diagnostic tests can sometimes add to healthcare costs without having a significant impact on patient care. But conversely, underuse of rapid tests can lead to suboptimal clinical outcomes. And in this regard, in some centres, laboratory test utilisation committees have been successful in overseeing some implementation of of diagnostic stewardship strategies. So a joint partnership, if you like, between the laboratory and the clinical services. And finally, it's all well and good to select the right test for the right patient, but actually this could have no impact at all on clinical care unless the result is quick enough and reported to the right people to influence the decision making. And turnaround time here is absolutely critical for the clinical impact of rapid diagnostic tests. And this table, in a recent article in JAMA from Morgan and colleagues, highlights some of the most common infectious diseases tests and potential diagnostic stewardship interventions. And I have to say that, many of these diagnostic stewardship concepts and principles actually emerged from Clostridium difficile testing, which was one of the first workflows in the laboratory to incorporate PCR testing. But I'm not going to go through all of these components of the table. What I want to focus on is, as I mentioned at the start of the talk, was something that was complementary to Professor Lai's talk, which was diagnostic stewardship applied to blood culture testing. So that is rapid pathogen identification and susceptibility testing from patients with sepsis. And the lab often focuses the attention there, and because these are arguably the most critical results that we generate in the laboratory. And here, this schematic illustrates, I guess, the major workflows based on three different scenarios of the progression in blood culture diagnostics with the development of molecular technologies. So the bottom workflow shows the conventional paradigm of testing. So this is what many of us still do at the moment in our laboratories and have been doing for many, many years. So there's growth in blood culture bottles, followed by subculture and purity plating, and then susceptibility testing. And as I mentioned, this is a sort of workhorse, if you like, of identification and susceptibility testing in patients with sepsis. The middle workflow, so workflow B, shows a new paradigm with earlier detection from the blood culture bottle. And the top workflow shows, I guess, what we could think of as the holy grail, if you like, which is direct pathogen detection and identification from blood without the need for bacterial growth in blood culture media. And I'm going to talk through each of these now. So the first one I want to talk about is direct detection of pathogens from blood. And so this is a blood culture independent method. So a blood test is taken from a patient and analyzed directly to identify pathogens. And at present, nearly all FDA-approved molecular diagnostics are post-blood culture technology. So meaning that a blood sample must be cultured to allow the number of pathogens to amplify before the diagnostic test can be conducted. And although this is a sensitive way of doing it, i.e. growing it in blood cultures, it really extends the diagnostic timeline. And also it can restrict the breadth of organisms detected because it relies on detecting only those bugs which can grow in blood culture media. So what I'm highlighting here circumvents that. And so these technologies function by rapidly amplifying pathogen nucleic acid, whether it's DNA or RNA, followed by different ways of detecting the pathogen. So for example, the SeptiFast method uses in situ probe hybridization. The Iridicaplex ID uses electrospray ionization mass spectrometry. And the T2 assay, which I've shown in the picture on the right, combines PCR amplification with magnetic resonance. And it's fair to say that we've come a long way, and these currently available platforms do show promise, but I think they've yet to definitively address gaps in sensitivity and specificity. And one of the major drawbacks at the moment is that they don't detect antimicrobial resistance. So in the context of antimicrobial stewardship at present, they have a relatively limited application. Why is it important to be able to detect resistance quickly? Well, for diagnostic and antimicrobial stewardship to work optimally together in sepsis, it's essential to have results that can guide appropriate antibiotic therapy. And this table here again from Messicaro et al., demonstrates some of the key AMS considerations for implementing these rapid diagnostics. And basically, the goal of AMS for rapid diagnostic implementation is to ensure that the right interpretation of the result occurs at the right time, leading to the right antibiotics. And if we think about the bigger picture here, in this review article by Holmes and colleagues in The Lancet a couple of years ago, the authors tried to assess the relative contributions of the drivers of AMR. And if you look on the right side of the slide towards the right of that diagram, they tried to assess some of the major drivers and, I guess, semi-quantitate, if you like, some of the major drivers of AMR. And interestingly, suboptimal rapid diagnostics and human antibiotic use and overuse were what they thought were some of the major drivers of AMR. And that goes some way to explain the importance of rapid and accurate diagnostics and antimicrobial stewardship. Okay, so how can we currently identify pathogens and detect resistance? Well, I would say that rapid detection from blood cultures are really the most advanced approved methods available. And as I mentioned, these involve detection from blood cultures, that is, after some bacterial growth. Why is this important? Well, if you think about it, growth in the blood culture media actually incorporates an additional specificity step. So by the time something grows in blood culture media, we can do a gram stain and say, well, this is a gram-negative bacillus or this is a gram-positive coccus. And there's a range of clinical experience emerging with these methods, particularly around MALDI-TOF-based detection from blood cultures and PCR-based identification and resistance gene detection directly from blood cultures, for example, in the BioFire and the film array assay. One thing I'm not going to go into in detail, but potentially has promise, is metagenomic approaches directly from blood cultures. So, for example, using Oxford nanopore technology, and that allows the detection of all of the pathogens and potentially all of the resistance genes directly from blood cultures. All right, finally, I want to talk about this method, which is a rapid phenotypic testing. So that's not just rapid identification of the pathogen and rapid detection of resistance genes. This is actually rapid detection of phenotypic resistance. You know, in reality, shortening growth-based susceptibility testing is biologically quite a difficult task because most antibiotics exert their activity by targeting some aspect of organism viability. So, for example, protein synthesis, nucleic acid replication, and therefore, in order for susceptibility testing to assess the activity of an antibiotic, the organism actually has to be replicating. One area, however, which has shown great promise in improving phenotypic susceptibility testing turnaround times is nanotechnology, partnered usually with microfluidics. And a number of companies have developed nanoscale susceptibility testing platforms that actually allow a huge number of organism and antibiotic combinations to be tested in a very rapid time frame. And one of the benefits of nanotechnology is that it can be scaled up. So it can allow for replicate testing within a single assay. And what that can help to do is to, I guess, mitigate some potentially aberrant results. And there are lots of methods by which nanoscale technology can detect organism growth, including things like optical density readings and fluorescence, secondary to activity in different metabolic pathways. And recently there was one FDA-approved rapid phenotypic test, the Accelerate Phenotest. So I guess I've talked so far about antimicrobial stewardship and diagnostic stewardship in relative isolation, but these authors recently in JCM proposed the concept of an integrated stewardship model, and I think that's really what we should be heading towards. So that comprises antimicrobial stewardship, diagnostic stewardship, but also incorporates infection prevention as well, and they've termed this model AID stewardship. And if you think about it, during an outbreak, the impact of rapid diagnostics can really be substantial and can directly influence infection control and treatment outcomes. Okay, so I'll just wrap up here and just summarize. I hope that I've convinced you that diagnostic stewardship has not only direct benefits to the patient, but also broader benefits to the population at large. And it's got multiple facets, really. It's used to guide clinical behavior, to reduce unnecessary testing and false positive results, but it can also be used to quickly identify pathogens and target appropriate therapy. AMS and diagnostic stewardship are absolutely inextricably linked, and a combined partnership I really think is essential for holistic stewardship. Diagnostics offer massive promise in improving patient outcomes, but really, we have to make sure that when we implement these in the laboratory, they're actually, they have direct value to the patient and to patient outcomes. Thank you for your time.
Thank you, Professor Williamson, for the very good talk. Very nice overview. I like the focus on the description around diagnostic stewardship and how it's linked to antimicrobial stewardship. I appreciate that our listeners are sending questions our way, so this is terrific. So we have some good ones to engage with our speakers. So I'm just going to get started. We're going to go through a few questions, and then we will click to the final slide to give you the code that you will need, and I'll review some of the instructions there. So to follow on something that you said at the end, Professor Williamson, we're seeing more and more where I guess the question is the role of the microbiology laboratory in getting engaged with the recommendations related to treatment guidelines, and how that's starting to change treatment guidelines around, if you say first line, second line, some of that's empiric, and more as rapid diagnostics become available, the empiricness is starting to go away. So I was curious if you could comment on that.
Yeah, look, I think that's an excellent point, and I think in an era where we've got critical levels of antimicrobial resistance, we cannot afford to rely on empiricism as the only means of, I guess, guiding our antimicrobial therapy, and that's been highlighted by a number of major organizations. And it was also highlighted in, Jim O'Neill's report on antimicrobial resistance, where, improving rapid diagnostics was determined to be one of the ways in which we could mitigate the AMR threat. So I think if your laboratory can afford the time and the resource in implementing rapid diagnostics with a view to quickly directing appropriate antibiotic therapy, then that's great. And what I've mentioned a lot about molecular rapid diagnostics, but that also it could be something as relatively low maintenance as doing direct susceptibility testing from blood cultures using discs, and that's something that we are looking at, for example, in the laboratory that I work in. I hope that's answered your question.
Yes, it does. And that was actually another question, was about the role of the e-test as well. I know you didn't necessarily touch on that, but some laboratories use the e-test.
Yes, so we use the e-test as well, and I think that I would put that very much in the bottom workflow of the schematic that I showed. I think it's a stock standard component, I guess, of many clinical microbiology laboratories, and generally the e-test is incorporated where blood culture has, and I'm just focusing on the blood culture workflow, but a blood culture has flagged positive, it's then subbed out onto a plate, the pathogen is identified, and then the e-test is used, I guess, relative to what that pathogen is. So, for example, you wouldn't test some gram-negative and active agents against Staphylococcus aureus, for example. So, yes, e-tests are important, but I don't think that they will be integral in reducing the turnaround time to appropriate antibiotics, but they're clearly an important part of the microbiology lab.
Yes, I appreciate that answer. The workflow is longer because of all the steps in between, but recognizing some laboratories do use them. Professor Lai, I'm going to bring you back live. The audience members really appreciated your case and would like to know the answer to one of your questions. And your patient case, you talked about the oral step down, and maybe just describe what you mean by that. And then I'd like to know the answer to how would you administer the antibiotic? Do you do entire course IV for 1 week, IV for 2 weeks, et cetera, et cetera? What's the answer to the question there? Or to de-escalate?
Thank you for the question. So this patient, if you look at the situation before we have the CT scan, you can actually give IV antibiotics and then convert to oral step down for 1 week. Now, why do I say that? Because the Israeli randomized control trial has now provided evidence that in uncomplicated gram-negative you do not need to give 2 weeks. And it is not wrong, however, to give 1 week of IV antibiotics as well, because in the same randomized control trial, it is about 60% of doctors treated a patient with full course of intravenous, and 40% treated the patients with IV to oral step down. And the most common oral antibiotic used in the Israeli trial is ciprofloxacin. However, I use the CT scan to illustrate the importance of thinking about complications when a case demonstrated some indicators of severity. This patient's fever settled immediately, but we started off with a white cell count of 41,000. And that CT scan showed portal vein thrombosis. Now, with that in mind, the duration will have to be 6 weeks. Now, having said that, that is expert opinion at this stage. There's no randomized control trial to examine septic thrombophlebitis. However, oral ciprofloxacin will probably do just as well as IV ampicillin in this case because of its oral bioavailability and its activity against E. coli in this case. I hope that answers the question.
Yes, thank you. I'll follow on to that, and maybe it's something that either of you, maybe Professor Lai, you answer first, and then if Professor Williamson, you may have a comment too. It has to do with when to obtain the blood or urine cultures. Is it better to have blood urine culture before any antibiotic treatment, or is it enough to get culture samples before? I guess they want to know if it's enough to get culture samples before antibiotic therapy. I think what they're saying with that is, do we need to have the results back before we start therapy, or do you get the culture, send it, and then first start the empiric IV antibiotics?
Yes, thank you. So it's actually, if a patient is sick enough to need the blood cultures, it also usually will mean that you need to start your IV antibiotics as soon as possible. The only exception, possibly, actually there are two exceptions, is in endocarditis, because in subacute endocarditis, you may have time to wait. And then in the investigation of fever unknown origin, because the blood cultures, you are just trying to exclude endocarditis actually. So in the other situations, there's acute bacterial infections, such as pneumonia, pyonephritis, hepatobiliary infections. You probably shouldn't delay intravenous antibiotics for too long and wait for the results. As demonstrated by Professor Williamson, the yield of blood cultures will take a while. But you definitely should collect the blood cultures before you start IV antibiotics, because it's been shown in quite a few studies that after IV antibiotics, the yield of blood cultures decrease dramatically by up to 90%. And that's why I highlighted the study shows that you don't have to wait for 2 hours or at a height of fever. You can just collect 4 bottles or 6 bottles of blood cultures from 2 arms. Make sure it's 10 minutes per bottle and start your empirical IV antibiotics. Thank you.
Thank you. Professor Williamson, I'm going to ask you a couple questions that are linked. The listeners are wanting to know, do you apply rapid diagnostics on a normal day-to-day basis in your laboratory?
Yes and no is the answer there. So
that's great. Yeah.
So the workhorse in our laboratory would be the paradigm that I showed at the bottom. So blood culture flags, subcultured, and then we use an automated susceptibility platform, plus or minus e-tests or discs, depending on the pathogen. Having said that, we occasionally, depending on the clinical scenario, we may use rapid pathogen identification from blood cultures using the MALDI-TOF, and we have begun to trial the BioFire platform that I mentioned on positive blood cultures as well. We employ the BioFire when we have a yeast, and we are looking at it in other scenarios as well. So I would say that we are, at this stage, dabblers, but that's something that I would like to move the laboratory towards, because I can definitely see the benefits of it. Having said all of that, I think we have to be able to work with our infectious diseases colleagues and the people who hold the purse strings to make sure that we implement these methods in a way that is cost effective. So I hope that answers your question.
It does. That's good. That tells the real world setting and what the desires are and potentially what the constrictions are. Because some of the listeners have even written that some of their organizations the rapid diagnostics tests are not available. And some of them even have to send out their microbiology test, and it takes 3 days to get the result back. And do you feel that's acceptable?
Quite honestly, for a sick patient, no, I don't think that that's acceptable. I would just say that in settings like that, local antibiograms can be useful as well. So knowing your local resistance patterns, having local therapeutic guidelines based on your local resistance patterns can be useful.
Very important. Absolutely. I'd like to ask Professor Lai that same question about whether or not you use rapid diagnostic testing at the moment in your clinical practice.
In my hospital, because we use direct sensitivity testing from blood culture, we'll usually know the gram stain within about 6 to 12 hours. We'll know the species by 24 hours, and we'll know the sensitivity by 48 hours. MALDI-TOF accelerates the identification, but here we use VITEC for the sensitivity testing. So usually it's about 48 hours. So we don't use the truly rapid system like BioFire. Importantly, in the randomized control trial that was performed, providing doctors with the results of the rapid diagnostic assay alone may or may not change decision in the following ways. In that particular trial, if an antibiotic is inactive, the doctor will change to an active antibiotic. We call it escalation. But if the antibiotic is active, the doctors actually will not de-escalate unless they are advised by Antimicrobial Stewardship to do so. So it gives some insights into how one can apply rapid diagnostic assays in the real world. And that study was done in the United States in Mayo Clinic.
Excellent. I'm going to just pause here. We still have Q&A going on. I have several questions, just at least 3 more I'd like to pose here. But I would like to advance the slide. Our host could advance to the last slide so we can give the code for this webinar. No, Deborah, if you still have control of the screen. Maybe it's me now. I'll advance it. There we go. So this is the information that I wanted to represent to our listeners, and then I have a question back to Professor Lai. So you've listened to our webinar, and if you'd like to receive continuing education, including CME, you will need to go to this website. And again, we will be emailing this out to all of our listeners today, but this is the information you will need. There will be a post-test question, there will be evaluation, and there will also be another link around feedback for the webinar. But the deadline to go in and take this test and receive credit for this live webinar is December 6th, and you will need this attendance code at the bottom. So write this down. Your attendance code is So write that down as you're looking on the screen. I'm going to actually go back to Professor Lai and ask a question. In your clinical case, this is related to C-reactive protein or procalcitonin, and it relates to a question that's come in around one of the world what's happening in their country. But you posed the question, would you order C-reactive protein or procalcitonin? And clinically, what do you normally order or use? Professor Lai.
So the biomarkers are definitely helpful, but I use that question to illustrate that if you don't use it in the right way, it can be wasteful. So for example, in this patient, most patients will get a full blood count. And in this particular case, the white blood cell was exceedingly high, 41,000. In this setting, there's absolutely no value in having a C-reactive protein or a procalcitonin because it adds nothing to the decision making. Likewise, if a patient presents with cellulitis or has a wound that is purulent, there's no need to have a CRP or procalcitonin because clinically it is already infected with antibiotics. The biomarkers are most useful to guide decision making when it's not clear whether there is an infection with bacteria or whether the infection is serious enough to warrant antibiotics. I think that is the key considerations to reduce wastage of usage of laboratory investigations. I hope that answers the question. Yes, I mean the question was basically in their particular setting, the procalcitonin test was cost prohibitive, so the go-to test for now is the C-reactive protein, and wondering if that was, in your opinion, still predictive enough for bacterial infections. Yeah, I think it's totally fine using clinical history and examination supplemented by white blood cell count as well as C-reactive protein. We started using ProCalc several years ago, and I think we need a ProCalc stewardship in my hospital. There's a lot of orders of procalcitonin and absolutely no impact on the antibiotic decision making.
Professor Williamson, thank you very much, Professor Lai. First of all, I'm going to ask you, potentially, this may be a hard question for you, but you may have some experience in low resource countries. This question said in a third world country where diagnostic tools are limited, what is the best way to practice diagnostic stewardship to try to prevent the spread of AMR? You know, the right interpretation, right antimicrobial. Do you have experience with this?
I guess limited experience, and I guess based on discussions with colleagues who have more experience, but one of the, I guess, fundamental components of robust laboratory results is ensuring quality assurance of testing. And so, you know, I think in a low resource setting where it can, I believe, sometimes be difficult to access even media used for susceptibility testing, or discs or even e-tests, you know, making sure that the reagents and workflows are quality assured, I think would be a critical step. But David may wish to comment.
Professor Lai, do you have a comment on this or experience in trying to practice diagnostic stewardship, antimicrobial stewardship with low resources? Limited resources, I should say.
Yeah. So, for example, when it comes to biomarkers of infection in a low resource setting, I definitely won't recommend anything beyond the white blood cell count. I do think blood cultures are very important because in a lot of low resource setting where I visited, one of the frequent feedback is patient doesn't get better, and despite a long course of broad-spectrum antibiotics. That blood culture that you sent at the start of that can be very useful in ruling out the presence of a true bacteremia, provided you have sent enough. So it is actually far more important to invest in that than investing in 2 weeks of broad-spectrum carbapenem, for example, because that results will help you in saying there is a true bacteremia, or perhaps there's no true bacteremia, and you look elsewhere for the reason of the patient's illness. So I do think, and I pick this case particularly to illustrate the importance of blood culture.
Excellent. I have a final question. I know we've gone just a little bit over here, that it's for both of you. So it ties in with the de-escalation that you described, Professor Lai, and in addition to that, the combination of rapid diagnostics. So how we might be able to utilize rapid diagnostics to facilitate the de-escalation, and how the laboratory, this also ties in how the laboratory scientists can then help educate the physicians towards using the test to help drive the de-escalation of the antimicrobials. Would you like to answer that? Perhaps Professor Williamson first?
Yes, look, I think that really only comes with, you know, clinical experience of the test, and so you know, one of the key ways I think that those tests can help in de-escalation is having, I guess, a high negative predictive value for, or you know, being able to rule out the presence of certain resistance genes, for example. So, you know, saying something doesn't have a carbapenemase resistance gene or doesn't have an ESBL gene, and that means, you know, that can help to de-escalate antimicrobial therapy. But that's not something that I think Professor Lai alluded to this earlier. You know, if say for example the laboratory introduced a test, and then the next day expected, you know, a shift in the way that a shift in clinical practice. You know, in reality, I don't think that that's going to happen. It comes with, you know, clinical experience of the test and a feel for how the test performs, not just in the laboratory and clinically. And it really comes back to the point I made earlier about, you know, a close partnership between the laboratory and clinicians.
Professor Lai, would you like to comment as a final question?
I shall. So one of the cheapest rapid diagnostic test is actually the gram stain. So if you do a blood culture and it shows gram-negative rod, then you can focus on the treatment of gram-negative bacteremia. Now with gram-positive cocci, with gram-positive cocci in cluster, it's a bit harder because you can't be certain whether it's the Staph aureus or whether it's contaminant. But beyond this, you know, for example, we found it very useful that a patient with prolonged fever, influenza PCR was positive, we could immediately stop the amoxicillin clavulanic acid given for presumed pneumonia. And in Singapore, as well as a lot of the low-resource tropical countries with endemic for dengue, if you're dengue NS1 that's positive because the fever lasts 5 to 7 days, it allows you to focus on the management of dengue rather than empiric antibiotics for prolonged fever. So there's definitely value in selecting the right rapid diagnostic test in the right setting, tailored to the local epidemiology to use to de-escalate unnecessary antibiotics in this age of antimicrobial resistance.
Excellent. Well, I'm going to conclude. We're at the end of our time allocated here for both of our speakers. I wanted to thank Professor Lai for his time and preparation for this webinar and really bringing the clinical experience to this discussion. And Professor Williamson, for your time and insights as well, and your laboratory perspective, and really showing how the two of you intertwine with your expertise and able to drive reduction in antimicrobial resistance, stewardship, and diagnostic stewardship as well. So to close, I wanted to just remind the listeners that you will be directed at post-webinar to a feedback site as well to give us feedback on this webinar. Also, I have the CIDRAP Antimicrobial Stewardship Project website screenshot there in front of you, as well as our link where you are able to go, and this webinar is also been recorded and will be available on our website where we archive them. As well as if you're interested in our content or giving us feedback for our next webinar, please engage with us there through our information as well as our newsletter. So thank you very much, and thank you to our speakers today.
Thank you, Marnie.
Thank you, everyone.